I'm Louis Pasquale, and I'm truly honored to speak in the President's Symposium. The title of my talk is Progression Despite IOP Reduction, Non-IOP Lowering Treatments for Normal Tension Glaucoma. Here are my disclosures. Relevant to this discussion is that I am supported by the National Eye Institute to study the pathogenesis of primary open-angle glaucoma, and I receive unrestricted support by Research to Prevent Blindness in New York City, also to study this problem. I would say that progressive normal tension glaucoma, and I put this in quotes, is a public health problem. Unilateral blindness rates from normal tension glaucoma have been estimated at 10% in 20 years. Bilateral blindness rates from normal tension glaucoma is about 1.4% in 20 years. In most instances, we do not identify the real reason why patients are progressing. And there are no proven ways to halt progression in normal tension glaucoma, either by IOP lowering or by non-IOP lowering approaches. Therefore, I would put out a call for an international consortium devoted to solving the problem of progressive normal tension glaucoma. We need a wisdom of crowds approach to halt this condition, which is really one of the scourges of the 21st century. With that said, let's get started. We need to know why a quote-unquote normal tension glaucoma patient is progressing, and it's important to start out by saying that not all progression is glaucomatous. Here's a 74-year-old white male referred for evaluation of normal tension glaucoma, and you see some increased cupping in the left eye. The visual field showed a unilateral superior temporal hemianopsia. Whenever this is seen, this is a pituitary tumor until proven otherwise. And in fact, neuroimaging studies confirm that this patient had a pituitary lesion, and prompt neurosurgical intervention resulted in resolution of this defect. So some non-glaucomatous red flags include very rapid progression, greater than 1 decibel per year, dyschromatopsia on Ishihara color plates, assuming there's no congenital dyschromatopsia, and visual field defects that respect the vertical. Next, we need to know how fast a normal tension glaucoma patient is progressing. Typical progression for this disease is about 0.2 to 0.5 decibels per year, but some patients can experience rapid progressive rates between 1 and 2 decibels per year. Rapid progression greater than 1 decibel per year should prompt more detailed IOP profiling. For instance, consider this 48-year-old yoga instructor who comes in for her third opinion regarding quote-unquote normal tension glaucoma. When asked about her occupation, she indicated that she ran classes in yoga where she did a lot of headstand posturing. Intraocular pressure tested during headstand posturing revealed an IOP of 50 millimeters of mercury. Intraocular pressure, and this paper I think is very important, tends to be highest in the earliest AM when nitric oxide signaling tends to be lowest. This is a study published recently in Ophthalmology Glaucoma of 176 patients given an eye care home tonometer. They were genotyped at 146 loci associated with intraocular pressure. Those with the highest genetic predisposition to elevated intraocular pressure had early AM IOPs that were 4.3 millimeters of mercury higher than those with the lowest genetic risk score. This resonates with me. This is one of my patients with quote-unquote progressive normal tension glaucoma, despite multiple intraocular pressures in the office that were in the low teens. The patient acquired the eye care home tonometer and received accurate measurements at 5 a.m. in the morning into the mid-20s. He underwent phacoemulsification, IOL with hydrus and ab internal canaloplasty, and resumed early AM intraocular pressure readings in both eyes. The treatment was in the right eye, and the intraocular pressure at 5 a.m. was 12 millimeters of mercury and 22 millimeters of mercury. These outside of the office intraocular pressure readings could be very important in explaining why these patients progress. Other aspects of the history that might be important is inquiring about sleep history. Patient with daytime somnolence may benefit from a sleep workup. Inquire about systemic hypertension and the use of blood pressure medications, and consider the PM dosing closer to dinner time than to bedtime. Also ask about dental health. Encourage a proactive approach to the treatment of periodontal disease. While it's unclear whether these things really impact the natural history of normal tension glaucoma, the patients will benefit from these types of questions and follow-ups. A strong family history of normal tension glaucoma starting in young adulthood should prompt a search for Mendelian variants. Mendelian variants associated with normal tension glaucoma include optineurin, TBK1, and myocillin. Collectively, they may account for about 3% of normal tension glaucoma patients. This is an excellent study documenting the natural history of treated TBK1 duplication normal tension glaucoma. And interestingly, what this study illustrates is that these patients have a genetic reason to have optic nerve vulnerability, but they only experience moderate progression. The issue is that they need single-digit target intraocular pressures, even though progression rates are not alarmingly high, because the disease starts at a young age. There's strong evidence that single-digit target intraocular pressures slow progression in open-angle glaucoma. Both of the studies listed here show pre- and post-trabeculectomy visual field progression rates. The visual field progression was reduced post-trabeculectomy among patients with pre-op intraocular pressures in the mid-teens. And it's this type of studies that prompted us to write this editorial that trabeculectomy must survive, because trabeculectomy represents a relatively safe and effective way to achieve these single-digit intraocular pressure levels. Another group of patients who might benefit from single-digit intraocular pressures are post-refractive surgery patients with low corneal hysteresis. Low corneal hysteresis is associated with higher intraocular pressure fluctuation and more rapid progression of visual field loss in normal tension glaucoma. And this subject definitely deserves more attention and consideration when you are managing a normal tension glaucoma patient. What about meditation? Well, there was a randomized clinical trial in the American Journal of Ophthalmology that was published in 2020, and it had some interesting results. Meditation decreased intraocular pressure in primary open-angle glaucoma. Diurnal fluctuation of intraocular pressure decreased with meditation. Meditation had direct impact on trabecular meshwork gene expression. Actually, these patients underwent trabeculectomy and had this study performed and found upregulation of neuroprotective genes, downregulation of pro-inflammatory genes, as well as upregulation of nitric oxide synthase 1 and 3, which are presumed to be beneficial in preventing or reducing the rate of progression of glaucoma. So, the successful management of normal tension glaucoma involves ruling out non-glaucomatous optic nerve disease. Know the age of onset and the rate of glaucoma progression in these patients. Consider what is causing the progression, even though a lot of times you're not going to know the answer. Rule out intraocular pressure spikes outside the office and set a target intraocular pressure that's appropriate for the age of the patient and the degree of damage for which they present. I will point out that while my topic was about non-IOP strategies for normal tension glaucoma, most of these strategies still involve intraocular pressure directly or indirectly. Most of the time, we don't know what's causing progression in normal tension glaucoma. I believe that improved resolution of the genetic architecture for primary open-angle glaucoma will help with precision medicine solutions for progressive normal tension glaucoma. And I'd like to reiterate what I said at the outset, and that is I believe we need a consortium effort to tackle this problem. Thank you for your attention.